All right. Good Friday morning, everyone. Welcome to our session right now on supporting patients with co-occurring stimulant and opioid use disorders. My name is Howie Fruitman, and I'm from CAMH, and I'll be here moderating today's session. Our fabulous presenter today is Dr. Tanya Hauck. Dr. Hauck is an addictions psychiatrist and clinician scientist at the Center for Addiction and Mental Health, as well as an assistant professor in the Department of Psychiatry at the University of Toronto. Her research and clinical interests include the epidemiology of addictions and addiction psychiatry in Ontario and stimulant use disorders. Please welcome Dr. Hauck.
Thank you. Okay, here are the slides. Thanks so much for having me, everybody. I do want to say, if people have attended my recent Medify talk, there is no major new news in the stimulant use disorder treatment world, unfortunately. So I have attempted to focus this a little bit more on opioids, but unfortunately, we really still are looking for evidence-based treatments. I don't have any commercial interests. This program hasn't received any financial or in-kind support or identified conflicts of interest. I don't have any relationships with industry, and basically everything is off-label. I'm just going to keep saying that, but essentially that's true for stimulant use disorder. And I did include some composite cases that don't represent any particular person. I show this slide, and I have since 2019 when this news article came out, because I think this is still really relevant, and that people who use stimulants still really experience a lot of difficulty accessing services and stigma, and often fall between the mental health system and the psychiatric inpatient system and the outpatient addiction system, and that it's really hard to access services. Still, I think this is really getting better thanks to efforts from many organizations, including CAMH and Medify and others. However, it's still really challenging. So thinking about what it's like when someone is struggling with stimulant use disorder and some of the symptoms of that, and trying to access care. So the objectives today are to talk about the epidemiology of stimulants and stimulant use disorder and some trends, talk about the evidence for pharmacological treatments, and including stimulant replacement, which is getting more attention and research at this time. Briefly outline contingency management, and I'm happy to talk about that more, and there's some references I can also direct you to. And then talking about stimulant-induced psychosis and talk about referral and treatment options. So I am hoping to leave time for questions as well, which would be really helpful because I haven't done this talk before for this audience, and I think the interaction with opioids is really, really important. And I just want to highlight, it's really helpful to be invited to do this talk. People don't present with one disorder only. Concurrent is really the rule, not the exception. Huge overlap with opioid use and stimulant use in mental health and psychosis and PTSD and many other diagnoses. And so thinking about this as a concurrent illness, I think is really helpful for all of us, no matter where our piece of the healthcare system might be. So I have a first case, and if you want to put things in the chat, that would really help. I didn't do any multiple choice questions, but I think getting some ideas of how you might approach this, or if you have questions, I'm going to probably do questions right before the second case and then again at the end. So this is sort of a hypothetical case. Carla is a 45-year-old woman who's been couch surfing, doesn't have stable housing for the last year. She's a long history of opioid use disorder with long periods of stability with methadone in the past. And now over the past 2 years, you've been treating her with buprenorphine extended release or Sublocade, and she's now in recovery from fentanyl use. However, during the period where she was using fentanyl until around 2022, she started to use substantial amounts of crack cocaine as well. And she's concerned about this. She wants to regain visitation with her children. So she comes in today for her buprenorphine and asks, can you help me with the crack? I really don't want to use anymore. So what are some options you would think about for her, either in terms of referral options, psychosocial supports, medication, psychotherapy, if you want to put any of those in the chat while I kind of go on and talk about some of the background. Just gonna down here. Okay. So in terms of the stimulants, really in Ontario at this point, we're really looking at cocaine, amphetamines, methamphetamine predominantly as stimulants that people are using. There has been some evolving concern about cathinones or bath salts showing up in the drug supply, but not a lot of clear data about that. But in terms of sort of main substances of use, so cocaine, a shorter half-life, primarily acting through blocking reuptake of dopamine, norepinephrine, and serotonin, and therefore increasing the levels of neurotransmitters, as opposed to amphetamines, methamphetamine in particular, blocking reuptake and also resulting in a massive release of additional dopamine, which is important because that in particular is quite neurotoxic and leads to some of the long-term effects of stimulant use. It is that increased dopamine in the nucleus accumbens that leads to reinforcement, and that depletion of neurotransmitters over time from those very high levels of release leading to neurocognitive effects. Approximately 7% of people using cocaine will start to develop tolerance in the first year. The epidemiology has really been shifting, and I think this twin-demic idea is really important. So we had declining methamphetamine use into the mid-2000s, and now really an escalation over the last few years. These are substances that were prescribed, and then when concerns started to be raised about them into the 1960s, they were reclassified as substances of concern and scheduled drugs. The use disorder is multifactorial, as with all substance use disorders, related to some genetic factors, but also psychosocial factors, concurrent disorders, mental health, and so on. But if you look at sort of the last decade, cocaine use between 2015 and 2021 has increased significantly from 0.3 to 0.9% of the population, methamphetamine from 0.7 to 1.7, and then among people using heroin or realistically now fentanyl, going from 9% to 44% in some studies. So a huge increase in concurrent use that we're seeing. And so when we're providing treatment, really thinking about the whole person, what their goals are, maybe having different goals for different substances, their psychosocial goals, and providing comprehensive care as opposed to focusing on one substance and the treatment of that substance, and sort of in the absence of everything else. What is stimulant use disorder? And I mean, again, just to remember, this is a pattern of use. Generally over a year would be the timeline, over 12 months, that is starting to cause the same criteria as in any other substance use disorder. So somebody presenting, saying, I use cocaine every couple of months, I don't have cravings for it. If I go without it, it doesn't bother me, and so on and so forth, would not meet criteria for a use disorder. So same kind of criteria, that there's more than desired over a longer period with a struggle to cut down, and impacts on social functioning, psychological health, physical health, employment, and so on, as well as hazardous situations, particularly driving safety being another concern, and tolerance and withdrawal. And the same criteria of severity in the DSM as with any other substance use disorder. So in terms of pharmacological treatment, this really hasn't changed. There is this great clinical need. There's been a lot of research for many years, and there's no well-established or broadly effective pharmacotherapy with ongoing trials. And so most treatments are short-term in terms of duration. I will say they also tend to be studied in the short term. They tend to be studied only up to 12 weeks or so. But everything is off-label. So in general, that is the case for any pharmacological treatment that we're looking at for stimulant use disorder. And just informing patients of that if you are going to try something, and being aware of that when you're offering things. In terms of things that we may want to look at or that have been looked at, thinking about what we're treating. So antidepressants, for example, generally speaking, don't treat the use disorder. That said, patients may want or need to be on an antidepressant for many other reasons. Stimulants are the only substance in the DSM that also it can induce an obsessive compulsive disorder. Antidepressants are the treatment of choice for many mental health disorders, ranging from OCD to major depression to generalized anxiety to PTSD. So there may be many other reasons, but they generally don't treat the use disorder. There's some concern from limited studies that sertraline actually reduces retention and abstinence. So more research in that area would be helpful to understand that, especially if somebody's been doing really well, for example, on a medication like sertraline for PTSD. Bupropion and mirtazapine are different. They do seem to have evidence for stimulant use disorder off-label. So bupropion in particular seems to reduce methamphetamine use. It is in the CADR guidelines off-label for ADHD, and it seems to be more helpful for people who are not daily users, but does have a potential for misuse. So if used nasally, can cause seizures. If injected, can cause necrosis, and so there is that risk, but can be quite helpful. Mirtazapine has been studied in several trials, and those trials have involved men who have sex with men. And I'm going to come back to this. There are some great new guidelines released last year that I do reference from ASAM and the AAAP. Really wonderful stimulant use disorder treatment guidelines that comprehensively go through all of this, that are really readable. And they talk about how, although these trials for mirtazapine were done in this population, it's generally felt that they can be generalized to the wider population, and that it's worth trying mirtazapine when clinically indicated for somebody who might be interested in that. Antipsychotics are not generally recommended to treat the use disorder. So you may be using them because somebody has psychosis, psychotic symptoms, but the use disorder, there's not any great evidence that they actually reduce the use of stimulants, and it's important to be clear about that. There's concern that stimulant users are at higher risk of neuroleptic malignant syndrome due to dopamine depletion or movement disorders, so to be cautious, especially about first-generation antipsychotics. There's some theoretical evidence about aripiprazole. It has a warning from Health Canada for impulse control behaviors, gambling, impulsive shopping, sexual behavior. It does not have that warning for stimulant use, but there have been some studies indicating a worsening or onset of stimulant use or worsening cravings when taking aripiprazole. That said, there aren't very many effective, long-acting injectable antipsychotics. So realistically, that's a trade-off and a balance for each person, depending on what the purpose of the medication is. And it is used in many settings for both mood augmentation as well as bipolar disorder and psychosis. Anti-craving medications and topiramate can be quite helpful for some people, but just to think about the population really carefully. So naltrexone, I put like a big warning. It's not something you want to use, of course, with OAT, but does have benefits. So I tend to think of this for somebody where they're not regularly using fentanyl. They've maybe had an accidental overdose. They use fentanyl perhaps once a month, or they've accidentally been exposed to fentanyl, and with great informed consent explaining that this medication is an antagonist for opioids, and that they should, ideally in those cases we have a urine sample showing that they're negative for opioids at the time we're starting the naltrexone, so we don't induce any withdrawal symptoms. Can be quite helpful for somebody who's, for example, had a long successful taper off of methadone or buprenorphine, and now may want to use this less evidence-based option for opioid use disorder, is not at that immediate risk of relapse and overdose. This can also be a great option. Pretty safe, as long as there's not really severe liver disease. It's generally considered safe with liver enzyme monitoring. Results in usually a small weight loss, and can be quite helpful, especially now combined with bupropion in some studies. That's been extra helpful for methamphetamine use, although very high doses. The other thing to be careful about is that bupropion does have a seizure history, and especially at 450 milligrams. So anyone who's had a seizure, for example, from contaminated fentanyl with benzos, from withdrawing, extreme caution and avoiding bupropion given the risk of seizures. Topiramate has some evidence as well. Anticonvulsants generally have not had a lot of evidence. Topiramate seems to be particularly helpful for some people using cocaine. That said, there is a teratogenic risk. It is a medication that has to be carefully titrated up and titrated down, which if someone's not generally taking the same dose of a med every day or missing days, it's not a great choice. And it can have neurocognitive side effects, which given the presence of neurocognitive side effects already with stimulant use disorders can be a real barrier to tolerability for that. And it does help with alcohol use off-label. So both naltrexone and topiramate for somebody who's concurrently, for example, using cocaine and alcohol, these can be good options for cravings for both of those. So this is kind of the big picture summary and sort of what I think about when talking to a patient about wanting to try something. So, there's nothing that's on label. Here are some things we could try. Let's try to pick something that might be otherwise helpful for you, that might help a concurrent disorder that you have, given your medical history and so on. So naltrexone, again, great if there's alcohol use disorder, then it's on label, first line. If weight loss is a benefit, then it's great. For example, because they're on an antipsychotic and they're gaining weight, however, they want to remain on the antipsychotic for mood or psychosis symptoms. It can prevent accidental overdose in someone who's not regularly using opioids. We would not use it if they were if they met criteria for opioid use disorder, needed opioid agonist therapy. Can cause nausea and weight loss. Of course, for some people, is a risk if they have low body weight or have an eating disorder. Bupropion may help with ADHD symptoms. Again, the sort of weight loss pros and cons. Helps with smoking cessation for patients where that's a goal, and is a good antidepressant. It's quite an effective antidepressant. On the other hand, the seizure risk, and it is an antidepressant, so it can worsen. It can cause mania in somebody with an existing diagnosis or strong suspicion of bipolar disorder, has a sort of lower level, but certainly risk of misuse in some individuals. Mirtazapine helps with insomnia off-label, is also a good antidepressant, can cause weight gain. So for some patients, that can be both a pro or a con. There may be some patients at low body weight who are actually struggling with appetite, and others where weight gain has been a concern. And adherence, sort of less of an issue. It's something if you take it some days and not other days, it may not work as well as an antidepressant, but it's not so hazardous in terms of having a withdrawal seizure or something. Again, the mania risk, it is an antidepressant. And topiramate, the benefit as well, so seizure prophylaxis for some clients, alcohol use disorder, off-label treatment, weight loss as well, kind of pros and cons, and the concerns about teratogenic effects and cognitive side effects and adherence concerns. Substitution therapy is getting a lot of attention. There are more trials going on. There's going to be an RCT starting at CAMH shortly, and certainly if anyone wants to reach out to me about several ongoing trials for methamphetamine use going on, I'm happy to answer questions. There have been some helpful reviews. So in general, there wasn't an improvement in retention and treatment, which is what we see with opioid replacement that we don't see with stimulant replacement. And again, being clear, if there's a well-established history of ADHD, then are we trying to treat that, or are we trying to provide this as a replacement therapy? How are we approaching this? Again, considering that the neurocognitive effects may not be easily and immediately remediated by a relatively lower dose stimulant if somebody is still recovering from long-term chronic stimulant use. It seems like these replacements do work better for cocaine compared to methamphetamine, which makes sense given just relatively how much more dopamine is released with methamphetamine use and trying to compete with that with a prescription stimulant. So in this review from 2020, really see like cocaine sort of more of a response than for methamphetamine for replacement. I do want to highlight again, replacement is not one blanket thing, as we all know from opioid agonist therapy. So providing somebody with 90 tablets of 60 milligrams of Vyvanse at once is very different from observed daily dispensing and monitoring. So there's a huge spectrum of how that could be provided. So for example, this study involved patients who had a history of heroin or diacetylmorphine use. They were on either injectable replacement with that. They were receiving methadone. It was very observed. It was a high degree of care and monitoring. The target substance was crack cocaine, so not amphetamines, and they were receiving sustained release dexamphetamine in response to that. There was very clear randomization and blinding. The doses were supervised. It had a good response. But they excluded anybody with acute psychosis. I just want to highlight that if this is something, based on the evidence you'd want to provide, just to be aware sort of the exclusion criteria of these slides in terms of psychosis in particular and mania. This is an observational study, so a large cohort of the population from Sweden with a diagnosed amphetamine or methamphetamine use disorder, and they again excluded anybody with a diagnosis of schizophrenia or bipolar disorder, and looked at sort of how different medications on a population level, observationally, changed hospitalizations or death, and lisdexamphetamine in particular seemed to have a benefit in reducing hospitalizations or death. Benzodiazepine use seemed to be associated with a worse outcome, but again, they're excluding really severe concurrent disorders, and it's important to think about that in treatment. So these guidelines are really great, the references at the end, and the guideline at the moment recommends stimulant medications should be prescribed with experience and with capacity for patient monitoring, just given sort of the consequences, especially psychosis, if somebody were to use sort of large amounts, the cardiac consequences of combining large amounts of prescription and non-prescription stimulants. Psychosocial treatment, to highlight, is really quite helpful. Compared to nothing, it really does work, improves adherence and abstinence, and there's a wide variety of treatments. I would say one of the struggles has been there aren't that many ways to access focused psychosocial treatment for stimulant use. I definitely know clients are seeking that and often sort of finding more general resources and really want resources focused on cocaine, methamphetamine use and kind of that pattern of use. I do want to quickly highlight, so whatever you're able to provide, whatever services your community has or that you're referring people to, just to be aware that stimulant-induced neurocognitive effects are not trivial. The substance use disorder framework and treatment system is often kind of created around alcohol as a sort of, and it is the most commonly used substance. And so just needing to consider, like, if the treatment plan is going to be going to a residential program where you're going to be sitting essentially in a classroom all day doing paperwork, that is quite challenging if you have significant deficits in attention, verbal memory, visuomotor performance. And so it's going to be hard often for clients to do well in those kinds of environments. And I hope that we start to address this and modify programs to be more tactile, to be more active, to be more understanding of some of the challenges in both acute and protracted stimulant withdrawal. And recovery is expected. It's just, it can take quite a number of months for that to take place. And I would also think about this if you're filling out ODSP. I'm going to mention that a couple of times, but somebody who's like the case, checking on that patient. One major intervention. Is that patient receiving ODSP? She's struggling. She's struggled now for a number of years. What are her symptoms? Is she having trouble with focus and attention? And even filling out the self-report, is that a barrier? Has she tried to apply to ODSP but been unable to organize the paperwork and needs help and case management from that? Is such a powerful intervention and part of sort of the road to recovery for a lot of people. Contingency management is by far the most effective evidence-based treatment for stimulant use disorder. It is massively underused, and I'm really excited that over the last couple of years we've seen such a growth all over the province. And so it's really simple. Starbucks and Tim Hortons and all these companies do this to us all the time by giving us rewards. It's a positive reinforcement operant conditioning framework. So you identify a target behavior that's important and measurable that you can actually measure. So it has to be something you can measure, like you can measure abstinence, you can measure attendance, you can't measure attitude, and unfortunately you can't measure a reduction in use, which is often a goal for patients. And you provide a concrete reinforcement, which initially was money, but could be goods or prizes when that behavior happens. And if the behavior doesn't occur, there's no reward, there's no punishment, there's just an encouragement to attend treatment, and it's meant to be enjoyable and rewarding and replace that surge of dopamine that's coming from the substance. And it could be even a small reward if you come to group on time. That's a really powerful one that works really well. So it's demonstrated the best effectiveness in the treatment of stimulant use disorders compared to any other intervention studied, and it is considered the current standard of care. So I'm so happy to see this, because when we started doing this in 2020 in the Brand Haldeman Norfolk RAM, it was unusual, and having to say, like, this is the standard of care. This has been actually well studied as the standard of care. It's just often getting it funded is a real challenge, and it's logistically challenging. And it's easy to combine with other things. So the way it would normally work would be twice a week. Patients would come in, do a urine test. If it's negative for the stimulants, they can win prizes. You can do it that it's a default prize every time it's negative, or more commonly, that every time it's negative, they get an increasing number of draws out of a prize bowl, and only 50% of those prizes or 40% of those draws are winners. That just lets you spend less money per person because resources are tight, adding that sort of draw component to it. And the more consecutive negative samples, the higher the number of times they can draw out of the bowl. So there's a couple of different ways to do this. I put the reference at the end. There's a cookbook written by Nancy Petrie, basically explaining how to do this. The challenge of it is really logistical. Where do you store the prizes? What prizes do you buy is the most common question I get. No one has an amazing answer for that, because it changes with time, right? It changes with what's popular right now. Asking the people getting the prizes is really the most powerful thing. And you can just add it to anything else. You can add it to a regular OAT visit, use the same sample. You can add it to a CBT group. You can have no group. We have clients who say, I don't want to do any other programming, and they just want to do this. And I think that's really amazing, because a lot of psychotherapy trials are done with a very carefully selected population with lots of exclusion criteria. So it's really powerful to have something that can be offered to everyone. And it's something that has really well demonstrated effectiveness, even with severe comorbid mental illness. It works well for individuals who've had trauma, maybe particularly responsive. We will say it's not going to treat those disorders, though. So although it works well in many populations, including people without housing, people with mental health concerns, you also have to, of course, address the other many mental health concerns that are going on. But it's definitely something, if you can provide it, that works well. Combo treatment, I'm not going to say a lot, but it's in the slides. It's just that obviously given that we don't have anything that works very well by itself, the more things you can layer on in terms of psychosocial supports, case management, medication, psychotherapy together, the better the outcome you're going to get. And the evidence does support that, although obviously we haven't seen sort of everything separately tested together. Okay, any questions at this point in the chat? And I'm going to read about the second case if anyone wants to add any questions. So the second case is Sven, who's a 24-year-old man at the local shelter. He has been using fentanyl and methamphetamine for many years and has had periods of improvement and stability with high-dose methadone and now slow-release oral morphine combination. Over the past year, he's struggled with missed doses, restarts, and increasingly paranoid and disorganized behavior. This week, a peer support worker in your clinic offers him snacks, and he stays longer and he tells you about his symptoms. He's using methamphetamine daily, and he's hearing the voice of someone he describes as the military commander all day, telling him he will be arrested. He's seeing signs and billboards that he feels are warnings to him. He ran out of CMHA last week because the caseworker used a computer and he thought he was being watched, so he didn't finish his ODSP self-report. He did get some sleep yesterday because he was admitted to hospital after being disorganized in the shelter, and then was released this morning. And he's sort of open to the idea that methamphetamine is causing some of these mental health symptoms. And he says, can you help me? Is there anything you can do for this? I'm so scared. Please make them go away. So I'll let everyone kind of think about that. If anyone wants to add anything about that to the chat. Thank you, Allison, just asked about if there's a guaranteed payout or token system or guaranteed reward. I think it's just about your clinic and what works in your clinic. Token rewards are a bit different because they don't have an immediate reward, because you're kind of storing, the client is like accumulating tokens to spend on something. And I think in certain populations, that's been valuable. I've heard that, like from our drug treatment court, that's a system they use more of, and it provides sort of this longer engagement. Traditionally, for stimulant use disorder, you'd want to be getting rewards twice a week to be reducing, to be getting people kind of from each, twice a week period to the next to avoid use. And I think really the guaranteed payout in the form of prizes is the most cost effective. The monetary is just more expensive than buying prizes because you can buy in bulk, you can get donations, and the prizes can be really fun. And you have like a prize cabinet that's set up so clients can go, and they're supposed to be able to go and look at it and encourage themselves because they want to win a particular prize. So I think cash versus non-cash is really a financial issue. Token versus immediate is just what the goal is. For stimulant use, usually the goal would be like an immediate payout. Variable. Yeah, so again, sort of really depends on the patient population. The draw is just popular because it's been tested more, and it tends to be the sort of standard model. That said, the draw or the raffle, it tends to be very labor intensive because somebody, and this is the part we don't think about, somebody has to like make that and do that and do the system and store the rewards and the logistics. It's a lot easier logistically to just buy a whole bunch of $5 gift cards or $10 gift cards and keep those on hand. So part of it is like, what is the clinic or system able to manage? Sorry, so going to Sven, I also like to show this image, which is the SAMHSA 4-quadrant model. And I appreciate Kinjal's point. Yes, he might be having schizophrenia and needs to be put on Seroquel. So yeah, like we should treat this. He's really struggling. He's really suffering. And SAMHSA talks about, if we think of a spectrum of less severe to more severe mental health and less severe to more severe substance use, I think, if we think about outpatient care, we were sort of envisioning treating quadrant 2 and quadrant 3. And realistically, it's individuals in quadrant 4 with more severe of both kinds of illness, where we would sort of envision they would be in an ACT team or be treated as an inpatient unit, that realistically they're presenting to outpatient clinics, and the wait time for ACT is now a year in many parts of the province, and ACT teams are full across the province. So realizing that this is what we're seeing in our outpatient clinics and how to best support people as much as we can. So any kind of substance-induced psychosis is just the idea that the mental disorder is not better explained by schizophrenia, as is brought up, or another mental health disorder. That's generally based on a chronology. So did the symptoms predate the substance use? Can we talk to a family member who can explain that, and so on? And generally, the DSM has defined it as the symptoms not persisting for 1 month after intoxication and withdrawal. That said, the data really shows for stimulant use that 1 month is not long enough. A lot of people do have a huge improvement in psychotic symptoms, but it takes much longer than a month for them to improve. And so there's kind of a debate, and it's sort of a spectrum from really transient psychotic symptoms happening only at the moment of use and going away after the person sleeps, to completely persistent. At this point, we're calling it schizophrenia, and it's really a spectrum. I will just say it's really important to think about broad spectrum urinalysis, because I've had clients where they're constantly kind of being assessed and said, okay, once they clear the stimulant, they won't have psychosis. And we do a broad spectrum. There's no stimulant or cannabis in there or anything else that would explain the psychotic symptoms. So that really points to this is persisting, in the absence of stimulant use. And it's hard. It's hard in clinical practice if somebody comes to your clinic from a different region. There's nobody you can talk to who knows them. There's no records available, and you just don't know the time course of their symptoms, and they're not able to provide that history in that kind of detail. Again, wonderful guidelines provide a lot of clarity on this that I think we just didn't have even 5 years ago, saying that really if there are symptoms of psychosis related to or co-occurring with stimulant use, that they should be treated. And I would say really the safety issues of untreated psychosis can be really dire. People can harm themselves. They can be violent. They can really end up quite injured. They can lose their housing because there's behaviors such as fires or brandishing weapons because they're terrified that can result in them losing their housing in a situation where it's so hard to find any housing. So treatment is important. And also avoiding stimulants and modafinil in anybody who has psychosis or mania is recommended. Generally speaking, you can say a few things about what the psychosis looks like. That said, it's not diagnostic. It's not based on symptoms. It's not possible to differentiate stimulant-induced versus schizophrenia. But they tend to be more persecutory and referential delusions, auditory hallucinations, and less commonly the negative symptoms you might see in an early onset case of schizophrenia, like social withdrawal and flat affect. In general, persistence is much higher than I think was really anticipated. So up to 40% of people converting over to a persistent psychosis or schizophrenia, schizoaffective disorder, somewhere between a third of patients sort of over time. And that's sort of multifactorial, family history, differences between different individuals. Some people just more likely genetically to have a conversion, and also just the substance itself having a very high potential to cause psychotic symptoms. So treatment, I just want to say again, access to care is a really big issue. I show this paper a lot. And even just the odds of seeing a psychiatrist are substantially reduced if somebody goes to an emergency department more than 5 times in a year for a substance use disorder. Now that's outpatient care, and we can argue that perhaps the person is unable to get to an appointment, doesn't have a phone, can't be scheduled. But even hospital admission in this study is substantially less. So individuals who have multiple emergency room visits for substance use disorder, where we would expect that they have a high burden of mental health, are substantially less likely to be admitted to a mental health unit. And so it is really hard in many cases, and we all know sort of the barriers in accessing care, and that care is often provided in sort of isolated places, and this is really challenging. So thinking about treatment and referral, I don't talk a lot about referral. I will say concurrently thinking about what are your local referral options, and getting to know them and making that referral, as well as offering treatment. I don't have good data on this. It does seem that logically, given that this is a spectrum of, brief psychotic symptoms with stimulant use, going over to schizophrenia on the other end, people tend to be along that spectrum, and so have more insight perhaps than somebody with long-standing schizophrenia. And so having a conversation is like really critical part of this, and naming it. It seems like you're having some symptoms. I wonder if those could be psychotic symptoms from the stimulants. That can happen. Providing information, and then talking about the person's goals and if they'd want to try a medication. So generally, if there are significant symptoms, and possibly an underlying primary psychotic disorder, trying to treat usually initially with an atypical antipsychotic. Things that we've experienced are, is it possible to get further history about the onset? Is there maybe a family member the person would be willing to have us speak to? Is abstinence likely or desired? Is that their goal at this time? The guidelines are often, achieve abstinence and reassess. Is that what the person wants right now? Can we sort of aim for harm reduction in terms of the mental health symptoms? What is the insight like into the symptoms? And are there significant functional impairments? So housing, personal safety, ability to seek medical care. And the part about opioids right now is this is a massive safety issue, and I'll come to a paper in a moment. People with psychosis and schizophrenia are dying at a substantially higher rate now of opioid overdoses, because if you have symptoms like conceptual disorganization, not being socially engaged, these are the factors where you're going to use suddenly a large amount of fentanyl. You're not going to have access to as much harm reduction equipment. You're not going to have as many people helping you out. These are huge safety issues that are really important. So I think, shared care is a really important factor. I'm just seeing the question. I'll come back to it from Sam about how does this work outside of CAMH. I work in the community as well in rural Ontario, and I think if you have a team or you're able to kind of generate a community of support and shared care, feeling comfortable trying out a medication with many clients, maybe not all, some will need some specialty referral, is a great start. So this is sort of our approach is reviewing the symptoms, the goals for this person, risks, benefits, alternatives. Would they want to go to residential treatment? Do you want to help facilitate that? Do they not? Talking about metabolic monitoring, which should be provided at least annually for everybody on an antipsychotic, and then try lower doses if they've never had an antipsychotic. I will say many people have had some exposure. There's limited evidence, but perhaps some suggestion that aripiprazole or arguably brexpiprazole are agonists as well, partial dopamine agonists, and could worsen cravings. But again, if that's a medication, for example, selected in hospital and it's worked well with a psychosis, the person may well want to continue on it because it's working for them. So for example, a treatment plan would be 3 milligrams of paliperidone for a week, seeing if there are any side effects, increasing to 6 milligrams, and then considering a loading dose of an injectable medication. Like I said, I think this looks different for everybody depending on their practice setting and their access to resources and support. Long-acting injectables are considered something you should offer to everybody with schizophrenia because the outcomes are better. And so we ideally try that depending on the client situation. But of course, you need to have the ability to provide that, to have monitoring, to have support. Other things to think about is, again, avoiding stimulant medications if they have psychosis, considering a long-acting, especially if you really suspect this is schizophrenia, it has become schizophrenia, if adherence is a challenge. Other things you can do is daily dispensing or even daily observed dispensing with client engagement and kind of reviewing the process with OAT. And then the pharmacist at least is involved and you have some sense of like, is the person taking this medication? So that's another option to consider. And it's really important to think about monitoring. This is really hard given the primary care situation at the moment as well. So abnormal involuntary movements, which can be caused by antipsychotics, and metabolic monitoring. And I provided some resources for those. And this is the AIM scale. It can be quite important to do, especially if somebody comes in and you see like noticeable tremor, and then being able to flag that, refer to psychiatry, think about other medication options. I just want to highlight, for schizophrenia, we know that the life expectancy is 15 to 25 years lower than the general population, primarily because of cardiovascular disease. And I don't think we have hard evidence, but the expectation is that's going to be similar for somebody with substance-induced psychosis. And so to monitor QTC if they're on methadone and an antipsychotic, and to monitor lipids and onset of diabetes if they're taking antipsychotics as well. I do want to add a few words before questions just about some of these factors. Again, I think these are things that really, ideally, we would be referring to psychiatry, and that there would be, a system of care available to people, including assertive community treatment, which are the intensive ACT teams. And I realize that those are things where access is a major issue province-wide. So in Ontario, capacity is presumed. We presume that everybody is capable to make medication decisions. And it's separate from detaining someone in hospital, detention, anything like that. So consent is based on capacity. There's no age of consent in Ontario, and our Healthcare Consent Act defines capacity as a person who's able to understand information about a medication and appreciate the foreseeable consequences. So it's quite nuanced. Able to appreciate is different from appreciate. Able to appreciate might be somebody being able to express, okay, I know my doctor thinks I have substance-induced psychosis. I'm pretty concerned and somewhat convinced that actually, there's extraterrestrials involved in my life, or that people are trying to stalk me on the internet, or whatever the concern is. I'm fairly concerned about that, but I understand what my doctor's saying. I appreciate that they think I have this disorder and they're telling me the treatment for that is this medication. And, this medication, I have to have some blood tests because I could get diabetes and I could get like muscle stiffness or a tremor and I should go see somebody. Like that's sort of the level of like, even if I don't 100% agree, I know, what you're telling me. And so I think this is really tricky because these are generally assessments that are done by psychiatry, often on an inpatient basis only. Being aware if somebody comes out of hospital and there's been a finding of incapacity and you get a discharge summary that says, this person's mother or brother or public guardian is now making their treatment decisions, not to then switch their antipsychotic treatment if that was what the finding was made for, as that would invalidate the finding of incapacity. So just to be aware of that. And they're very specific. So finding of incapacity would generally be just around one class of medications, so antipsychotics, mood stabilizers. It wouldn't be globally all medications. So they could be fully capable and often would be fully capable with, for example, methadone OAT, and may be found in, for example, in hospital incapable with respect to antipsychotic medication. And so there's seriously, I think, some implications on this, which is we're seeing this increase in stimulant use and psychosis among people using opioids. We can have persistent psychosis in people using opioids, particularly fentanyl, with a third even converting to a persistent psychosis. And so there was this recent study I alluded to from BC that the highest overdose mortality rate was actually among people with schizophrenia and psychotic disorder. And so there's many reasons why somebody might not be capable to consent to their medications. There could be psychotic disorder, which their delusions or paranoia about, for example, the methadone or the buprenorphine. There could be an anoxic brain injury from an opioid overdose that now the person, for example, has a neurocognitive disorder and a MoCA under 20 or some kind of a diagnosis like that, where they're not able to understand the information of the risk of overdose, of taking or not taking buprenorphine. They may have an alcohol-related neurocognitive disorder, however, also have a concurrent opioid use disorder. They could have a neurodevelopmental disorder. So all of these things, they may not actually meet the test of understanding and appreciating the risks and benefits of taking, and particularly not taking, methadone or buprenorphine. And this is just an area that has not received very much attention. And I'm really talking about the strict current Ontario criteria for capacity, not changing that. This is the current understanding of capacity for any medical decision that anybody currently would make in Ontario. And so I think we all, this is sort of an area for future development, is thinking about how we approach this if somebody does not seem to be capable of making these decisions. And how do we do that, given that 100% of the sort of community treatment teams are over capacity? We can't refer to them very easily, and access something like a community treatment order, which is a plan of treatment where if somebody isn't following the plan of treatment, their substitute decision maker, like their family member, could ask them to be hospitalized for stabilization. These things do exist, but availability is really the barrier at this point. Now, quickly, I just also wanted to mention, what if this patient then were in an acute crisis? I think this is a more practical matter for clinics. And just to sort of review, so if the patient came in with a weapon, was very paranoid, was agitated in the clinic, was threatening to harm themselves, or said they had harmed themselves because of the psychosis or other mental health disorder. And so just to generally review, there would generally be sort of 3 ways that could be done. So one would be a Form 1. So Form 1 can be issued by a physician. And just to remember that the Form 1 can be issued within 7 days of the assessment. So if somebody came into the methadone clinic on Monday, and then on Friday, their family member called and said, you remember how he was kind of talking to himself in the clinic and seemed really disorganized. Well, now he's saying this about me and threatening me and scaring me, and I had to leave the house because I feel unsafe. Then you have the 2 elements of the Form 1, which are that there is a mental disorder, so some kind of symptoms, talking to himself, hearing voices, being paranoid, and there's an acute risk. So acutely a threat to themselves, a threat to others, acutely and or a failure to care for self, like is sitting in the middle of the street, is not eating, is walking around outdoors in -10-degree weather without appropriate clothing, that sort of immediate threat to safety. So that's a Form 1. Again, remember, a Form 1 is an application for an assessment, so it does not require a definitive diagnosis. It just has to be those elements. You don't issue the Form 42. That's done once the person reaches a Schedule 1 facility, which is a hospital that has a psychiatric ward, in essence. And after it's issued, if the person leaves the clinic, the police have 7 days to bring them to the hospital after that. The second option is that someone, whether it's a person in the clinic or a person in the person's life, calls the police and says there's this concern, again, of this immediate safety issue, and under the Mental Health Act, the police can apprehend the person and bring them, again, to the hospital for an assessment. And finally, there is also a Form 2, and so anyone can do that. It doesn't have to be a family member. In the case of a Form 2, a person appears before a justice of the peace, so that's only available during business hours, explains the risk, again, the immediate risk. So saying, 2 months ago, the person did this, that's not the bar. It really has to be acute, explains what the concern is, and then the justice of the peace can decide to issue a Form 2, resulting in a police apprehension and an assessment in the hospital. So I just want to say again that there's a really big picture here that goes from ODSP, housing, community support, peer support, various forms of counseling, treatment of concurrent disorders, case management, the pharmacy, and thinking about daily dispense of either the OAT, but also potentially the antipsychotic or anti-craving medications and all of those things, contingency management if you're able to run a program, all of those things together. And I just want to highlight that can be such a powerful piece. And if patients don't have access to a phone, which can definitely happen not infrequently, and as well, things like Wellbutrin, bupropion, if a patient is at risk of misusing it, to provide it in more of an observed form. All of these things can be helpful. Or somebody who wants to call detox and can't call detox, sometimes the pharmacy will help them do that. Okay. I just really want to thank everybody in this talk, especially Stephanie Rashawn, who's co-presented a lot of these slides with me. The team at CAMH, who are listed here, as well as Dr. Tim Guimond, who's co-presented similar content with me, for all of their help, and the entire team at the BHN RAM, who provide this kind of treatment all the time. And then I'm just going to leave up some resources, and I'm going to leave this up, but there's a lot of references on the slides. Okay, so do you want me to read some of the questions in the chat? Okay. Okay, I'm going to try to answer your question, Sam. I don't know. It's hard. It's really hard. I think team-based care is really the way to approach this. I think these are not things we can easily do ourselves as individual providers. Things like e-consult, reaching out to colleagues, finding referral pathways in your community. Those are all kind of ways that working with some of the resources in the community. So most communities will have non-medical addictions providers and agencies, which really vary widely, that do a lot of the psychosocial intervention, both inpatient and outpatient, and kind of knowing those services and seeing if you can actually co-locate. So I do think it is a major problem, and co-location is really important. These patients are often in incredible distress and discomfort from opioid withdrawal, among other things. And so asking someone to go across town to another clinic is not realistic, and having everybody in the same site is super, super hard. Okay. I don't miss anything. For patients who do not want to stop using stimulants but have experienced or are experiencing stimulant-induced psychosis, is there any evidence to support supplementation, even for a short period, for a patient with pharmaceutical stimulant, like oral dexamphetamine or lisdexamphetamine, injecting amphetamine, more in the context of acute care? So I don't know of evidence. The concern is really not adding to the harm. And so the guidance really at this time has been not to add stimulants if the person is having stimulant-induced psychosis. But I hear you, if the person absolutely doesn't want to reduce, I think, again, there would be an important concern about capacity. Like, is the person capably able to understand that that's going to worsen their psychosis? And I don't think we've really explored that or thought about that very much. Question from Tomoko about pediatric stimulant use disorder treatment. Beyond off-label, it's really challenging. I think it depends on the pediatric sort of question. So I'd say like 16 plus, I will usually sort of provide treatment like as if adults. I think involving pediatrics if you can, but this is a major gap in the system. There just isn't a lot of expertise and availability of services for youth, let's say 12 to 18, using stimulants. I think the attempt or gold standard would be psychosocial support, residential treatment. But again, that's a voluntary system and not everyone's interested in it. And so I think I have offered naltrexone, again, trying to involve family to support if the person is open to that, explaining that we don't have great data. Bupropion would be used sometimes in that population as well for depression. So that's another kind of option, mirtazapine as well. So you can kind of use most of the same medications with informed consent, but on a spectrum where, and anyone under 16, also given the situation, I would say we are, in all likelihood, I obviously can't speak to every situation, but there'd be a huge concern about child safety and involving children's aid. And so the context is a little bit different, but 16 plus, having an informed consent discussion with the person. Clonidine, I just going to say, I think mostly for opioid withdrawal symptoms. I think possibly some benefit for the ADHD kind of attentional symptoms that can happen, but not as much evidence. Question from Marnie about, can you speak more about why reduction of stimulant use is not immeasurable for contingency management? Just that traditionally it's hard to quantify. So it's meant to be a very non-emotional interaction, sort of like, this is the result, this is the prize. Understanding that, obviously even urine drug testing is not always correct, and that we're definitely using immunoassay for contingency management. So you can have false positives. That's sort of a risk, and we use the immediate test result, not maybe if we're sending it out for broad spectrum, we don't use that. So with reduction, we don't have a test that can measure that. The research has really supported it being an objective measure, like witness, the person came to group, I saw them come to group, they entered the draw for prizes. Reduction is entirely self-report, so traditionally hasn't been used for a rewards-based system where it's meant to be this external, objectively measured contingency. In theory, you could do it, but I don't know of any lab that rapidly could provide like a drug level, right? That would be kind of the requirement. I think in those cases, what's been more provided is like the person having a behavioral goal, like, I'm going to attend this program every day this week. I'm going to come to day program every day, and that would be a great thing, because like that would be easy to figure out. Alex asks, I think this is the question I already answered. Okay, yeah. Yeah, Luba's asking about naltrexone. So it is difficult. I would say a lot of times there has been a concurrent or past diagnosis of alcohol use, but that is not always the case.
I think that's it for our chat questions. if anyone, oh, I think someone's typing though right now. So let's give it a couple more minutes to see if folks want to add anything.
Yeah, supplementation in acute care. There seemed to be more about this a couple of years ago. I would say like symptomatic management tends to be more what's provided now. Mirtazapine can be really helpful. We use it a lot in outpatient detox. Supplementation, the usual issue is that many clients do have psychosis, and so that's very challenging in a non-medical detox to have somebody with like worsening symptoms of psychosis. So generally it is, it's a very different phenomenon than opioids. You don't have the overdose risk. It's a totally different kind of withdrawal. So really more like allowing people to recover, like allowing them to sleep, providing lots of snacks, maybe giving them some mirtazapine, maybe some olanzapine if they're having some psychosis. It's a very common, so like 5-TID olanzapine or quetiapine. That's sort of more an approach in an acute care setting for the withdrawal, and really treating the psychosis if it's a big part. So if they have, some people, it's a really brief, severe psychosis over sort of a couple of days after they stop, and it's terrifying, and they're 100% convinced they're going to die, and so providing treatment for that and a like safe place can be kind of the more important issue.
All right, everyone, I think we're at time right now. Dr. Hauck, thank you so much for your wonderful presentation. So folks, just to let you know, you have a bit of a 10-minute break between now and 11:35, at which time the following sessions will resume. Thank you so much for joining us today. I see one last question came in, though. I don't know, Dr. Hauck, if you want to address it. It's from Sam.
I don't think it's a big deal either way. I mean, like, it depends why you're tapering. There is a wonderful website called switchrx.com, which if you're tapering because you're switching to a different antipsychotic, will give you like a cross titration graph. If you're tapering because the patient doesn't want to take it, I mean, it's just like the faster they do it, they might not be able to sleep. And if they were on it for psychosis, they might develop psychosis again. So that's really more the issue. I think it's just more individual in that sense. I'll put that in the chat, actually, in case.
All right, everyone, thank you so much for joining us today. Go take a quick break, and I hope you enjoy the remainder of the day. Thank you, Dr. Hauck.
Thank you.